Hi, my name is Tahereh Noori. I'm a scientist at the MacCallum Cancer Centre in Melbourne, Australia. Today I'll be presenting a paper called Partial Syntaxin-11 Deficiency due to a hypomorphic variant, a self-limiting inflammatory disease preceding HLH onset.
And hello everyone, I am Aaqib and I was involved in the diagnosis and management of the patient, and I thank my colleagues Dr. Altaf and Dr. Anit for assisting me. So our patient presented at 16 months with intermittent fever, enlarged liver and spleen, and we noted cervical lymphadenopathy. Investigation showed mild nutritional anemia, cytotoxic T cell lymphocytosis, and decreased B cell counts. A detailed workup for infections was non-contributory. Although we noted mildly elevated levels of peripheral blood double negative T cells and bone marrow aspiration biopsy showed mild hemophagocytosis, the diagnostic criteria for familial hemophagocytic lymphohistiocytosis, FHL, or autoimmune lymphoproliferative syndrome, ALPS, remain unfulfilled at the initial presentation. Although we did not utilize any specific therapy except for hematinics, the child improved spontaneously and he did not require any further hospital visits for the next 8 months. Meanwhile, whole exome sequencing, which was performed at initial presentation, showed a homozygous missense variant in the syntaxin-11 gene, resulting in substitution of leucine at position 135 with proline, L135P. Unaffected parents and a younger sibling who was born subsequently were heterozygous carriers of the variant. Given that the variant was initially classified as a variant of uncertain significance, we sought help from Professor Ilya and Dr. Tahereh for functionally testing the variant. At 8 months of follow-up, the child again presented to us with fever, worsening hepatosplenomegaly, and generalized lymphadenopathy. On this occasion, the criteria for FHL were fulfilled, as we also noted neutropenia, thrombocytopenia, hyperferritinemia, hypertriglyceridemia, and elevated circulating levels of aspartate aminotransferase and lactate dehydrogenase. Meanwhile, functional testing had shown the variant to be deleterious, and he was treated according to the HLH 2004 protocol and is doing well currently. He is planned for a hematopoietic stem cell transplantation in the future. Over to Dr. Tahereh.
Thank you. The pathogenicity of L135P missense mutation in syntaxin-11 had not been previously assessed. Through our established unpublished experimental protocol, we were able to express this mutant protein in mouse CD8 T cells and show that it had severely reduced but not null function when compared to the wild-type protein. This suggested the mutation to be hypomorphic and thus explaining the patient's late onset of HLH. We could detect very little of the L135P syntaxin-11 protein by Western blotting, despite overexpressing in mouse CD8 T cells and in human CD8 T cells. The stability of the syntaxin-11 protein is regulated by its partner protein STX11. So we asked if this mutation affects the protein-protein interaction between syntaxin-11 and syntaxin-PP2, or does it inherently cause protein instability, thus leading to protein degradation? To answer this, we express the wild type and the L135P syntaxin-11 in the human dermal fibroblast cell line, BJ3, which expresses very little endogenous syntaxin-11 and syntaxin-PP2. Here, we can show that the expression of both wild type and the L135P increased proportionately when wild type syntaxin-PP2 was also expressed. This suggests that the L135P missense mutation does not affect its interaction with syntaxin-PP2, but does rather cause intrinsic instability in the protein. So, in conclusion, we have shown that using our established in vitro experimental protocol can be used to aid in the correct diagnosis in the cases of FHL without the need for patient blood, as was highlighted in this case.